Welcome back to the Deep Dive. Today we're peeling back the layers on something everyone thinks they know, but which hides a world of complexity. Eczema.
Mm,
And this isn't just, dry skin. It's a chronic inflammatory condition, and it's characterized by this profound, sometimes debilitating itching.
they call it pruritus. Right.
Right, pruritus. And that leads to rashes and a severe breakdown of the skin barrier.
And when we talk about how common it is, we are not talking about some niche issue. Eczema affects more than 31 million Americans. It crosses all demographics, all age groups.
Wow.
So our mission in this deep dive is to move beyond just that general term eczema and give you a really clear, usable framework. We're going to map out the 7 distinct types, look at the tangled web of causes, and most importantly, deliver the actionable knowledge you need for effective management.
I think that distinction is so vital. The difference between, say, simple irritation and this chronic inflammation. The sources really emphasize that while eczema is a form of dermatitis.
Right, a general skin inflammation.
Exactly. What sets eczema apart is that it involves this chronic inflammation, and it's driven by these really deep-seated genetic and immune system factors. It's like an internal war manifesting on your skin.
It is. And if you're one of the, 10.1% of the U.S. population affected? Or if you have kids globally, something like 15 to 20% of kids suffer from atopic dermatitis, just understanding that foundation changes everything about how you approach it.
Okay, so let's unpack the visual presentation first, because what you see is not always what you get, especially depending on your skin tone.
That is such a critical point for getting an accurate diagnosis. On lighter skin, the inflammation, it typically shows up as these bright red or pink patches.
Classic look we all picture.
The classic look. However, if you have darker skin, that exact same inflammation often presents as purple or brown or even gray patches.
And that could be misdiagnosed.
Or overlooked entirely because that redness is just masked.
That misdiagnosis is a serious issue.
Mm-hmm.
What really stands out to me in the material is the sequence of events.
Mm-hmm.
It all starts with that intense itching, but that's what leads to the breakdown, right?
It does. The itching is the motor. It drives the entire disease cycle. So that scratching, that leads to broken, dry, and thickened skin.
Mm-hmm.
And when the barrier cracks, you've opened the door to oozing lesions and secondary infections.
And if that cycle is left untreated, the consequences are long-lasting.
Very long-lasting. We're talking about permanent changes.
Permanent.
Irreversible texture and color alterations to the skin. And those chronically cracked areas, they're like an open invitation for common bacterial infections, most often Staphylococcus aureus.
Staph first.
Yeah, staph.
Yeah.
It loves to colonize compromised skin, and it triggers even worse flare-ups. It's a vicious cycle.
Before we move on, let's just nail down one major misconception.
Yeah.
Eczema itself is not contagious.
Correct.
It's an autoimmune or inflammatory response happening inside your body.
Mm.
You cannot catch it from someone.
Absolutely correct. But, and this is a big but, because the eczema has fundamentally broken that skin barrier, any secondary bacterial or viral infections that get in through those cracks, those can be contagious.
So the skin is your fortress, and eczema has basically just opened the gates.
Precisely. It's created breaches in the wall.
Okay, let's talk about the causes then. If we're thinking of skin as a house, we need to know why the foundation is failing. The sources break this down into 4 complex, often overlapping factors.
What's so fascinating here is that it's rarely just one thing. It's a convergence.
A perfect storm.
Exactly. So first you have genetic factors. Family history is key here, and it often points to a deficiency in one specific protein, filigrein.
Filigrein. Okay.
Think of your skin cells as bricks. Filigrein is the mortar that holds those bricks together and seals the barrier. Without enough functional filigrein, that barrier becomes leaky, it can't hold on to moisture, and it lets irritants slip right through.
So your skin is basically like a cracked sponge. It's constantly losing water and letting allergens just walk right in. That sounds like a recipe for constant immune trouble.
It is, which brings us to cause number 2, immune system dysfunction. Because all those allergens and irritants are getting past the weak barrier, the immune system just overreacts. It leads to chronic inflammation.
And this is why it's so often linked with asthma and hay fever.
That's the one. It's called the atopic triad.
Third, we have the more tangible environmental triggers. These are the things we actually encounter every day.
Right. Irritants like harsh soaps, detergents, certain fabrics like wool or polyester, and of course, airborne allergens.
Pollen, dust mites.
Pet dander, you name it.
And the fourth factor, and this often feels like the most frustrating one because it's internal, is stress.
Yeah, emotional stress is repeatedly flagged as a major culprit.
Why is that?
Well, stress releases hormones like cortisol that increase inflammation throughout the entire body. So for someone who is already genetically predisposed to eczema, that stress acts like pouring gasoline on a smoldering fire. It can instantly trigger a severe flare-up.
So if we connect this back to actionable strategies for you, the listener, what are some of the controllable risk factors that people should be tracking?
Okay, so climate and geography matter a lot. Dry, cold climates or places with rapidly fluctuating humidity can increase your risk.
Right.
Then, on the lifestyle side, exposure to secondhand smoke and even obesity are listed as contributing factors because they increase overall systemic inflammation.
And on a daily basis.
On a daily basis, be relentless. Avoid harsh, fragrant skincare, extreme heat, and just overly dry air.
Now, before we jump into the 7 types, let's just clarify the progression. You mentioned thickened skin. Can you quickly walk us through the severity stages?
Sure. It starts with the acute stage. This is the most aggressive presentation. Intense redness, fluid-filled blisters, leaking, crusting.
That sounds awful.
It is. From there, it can move into the subacute stage. The inflammation is still there, but the skin is primarily dry, cracked, and flaky.
And then there's the long-term consequence.
Right, the chronic or severe stage. This is when symptoms have persisted for months or even years. The skin adapts to all that chronic scratching by thickening up. It becomes leathery and scaly.
And there's a technical term for that.
There is. It's called lichenification. And understanding how deep that damage goes, this lichenification, is so crucial because your treatment really depends on knowing which of the 7 distinct versions of eczema you're actually fighting.
Okay, let's run through the full roster then, because it's really eye-opening just how different they are.
Absolutely. So starting with the most common, number 1 is atopic dermatitis, or AD.
The one we hear about most.
Right. This is the chronic genetic form, usually starts in infancy. It classically affects the flexural areas, so the inside bends of the elbows and behind the knees. This is the type that is most strongly linked to that filigran gene deficiency we talked about.
Okay, next up, the one that's a direct result of environmental contact.
That's contact dermatitis. It's a localized reaction to external sources, and it's divided into 2 types. Irritant, which is caused by harsh chemicals damaging the skin.
Like a cleaning product.
Exactly. And allergic, which is a delayed hypersensitivity reaction. It pops up wherever the contact happens, hands, wrists from a watch, or your lips from a cosmetic. The only cure is just strict avoidance of whatever's causing it.
Number 3 is really specific in its location.
Very specific. Dishydrotic eczema, or pompholyx. The unique identifier here is these tiny, clear, intensely ishy blisters, and they appear only on the palms of your hands, the soles of your feet, and the sides of your fingers and toes.
Yeah, what triggers that one?
It's often triggered by heat, stress, or contact with certain metals, like nickel.
Okay, number 4 is basically the definition of that itch-scratch cycle gone completely haywire.
You got it. Neurodermatitis. It's also known as lichen simplex chronicus. This is a testament to the power of the central nervous system. It results directly from the chronic, just habitual rubbing or scratching of one specific spot.
So you're creating the problem by scratching.
You are perpetuating it and making it much worse. That relentless mechanical action creates a single, localized, thickened, leathery plaque. That's the advanced lichenification we mentioned. You often find it on the neck, ankles, or even the genital areas.
The 5th type is fascinating because it's a circulatory problem that's just masquerading as a skin disease.
It is, and this is a vital distinction to make. Stasis dermatitis. This is not caused by genetics or allergies. It's caused by poor blood flow in the lower legs.
Venous insufficiency.
Exactly. When blood can't return efficiently to the heart, it pools in the ankles and calves. That leads to swelling, dark discoloration, and eventually skin damage. The treatment is all about circulation elevating the legs, compression therapy.
The name of the 6th one tells us its defining physical trait.
It does. Nummular eczema. Nummular just means coin-shaped. This type presents as these very distinct, intensely itchy, coin-shaped lesions.
And they can appear anywhere.
Anywhere on the body. They often show up after some kind of localized trauma, like a bug bite or a scrape, especially in people with very dry skin.
And finally, the type that affects the oily, sebaceous zones.
Right. Number 7, seborrheic dermatitis. This one targets areas high in oil glands, the scalp, the face, the chest folds. It looks like greasy, reddish skin covered in yellowish scale.
And the mildest form is dandruff.
That's it. The mildest form on the scalp is just simple dandruff. It's driven by an overgrowth of a yeast that lives on our skin naturally called Malassezia.
That list makes it so clear. Managing eczema requires a precision approach. So if you understand the cause, be it genetic, circulatory, or contact-based, what does the source material say is the essential first line of medical defense?
The treatment is definitely multi-layered. For mild to moderate cases, we rely heavily on topical treatments. So this includes your standard moisturizing emollients and critically topical steroids to knock down that acute inflammation.
But steroids aren't great for long-term use, or on sensitive areas like the face, are they?
Absolutely not. And that's where non-steroidal options come in, like calcineurin inhibitors, tacrolimus, and pimecrolimus.
Why are they so important?
They're key because they suppress the specific immune messengers that cause the inflammation, which makes them safe for prolonged use on delicate skin without that thinning risk you get with steroids.
And what about for patients whose entire body is affected or who just aren't responding to topicals?
Then you move up to systemic therapies. Historically, this meant broad immunomodulators like cyclosporine, or maybe a short, powerful course of oral corticosteroids for an emergency flare-up. But this is where it gets really interesting in modern medicine, the rise of biologic therapies.
Okay, tell us about the biologics. Why are they considered such a revolution in treatment?
Because they don't just broadly suppress the entire immune system, they act like a precision missile. Biologics, like dupilumab, which is also known as Dupixent, are these monoclonal antibodies that specifically block two key signaling proteins.
Okay.
These two proteins, IL-4 and IL-13 cytokines, are essentially the main conductors of the whole eczema inflammatory symphony. By silencing them, you dramatically reduce the systemic inflammation without widespread side effects.
That's a huge step forward. We also saw a mention of more advanced interventions, like phototherapy, which uses UV light.
Phototherapy can be effective, yes, but the sources caution that it requires really careful supervision because of the long-term risks.
Such as?
Accelerated skin aging and an increased risk of skin cancer. So it's a tool, but it's one you have to use judiciously.
The good news here is that home care and prevention are incredibly powerful. I mean, you can't prevent eczema if you're genetically wired for it,
No, you can't.
but you can absolutely control its severity.
Oh, absolutely. And the foundation of all home care is barrier repair. This means regular, religious moisturizing with fragrance-free, hypoallergenic emollients.
And timing matters.
Timing is everything. The best time to apply is within minutes of stepping out of a lukewarm bath or shower to lock in all that hydration. And, of course, diligently avoiding your personal triggers, whether it's wool, heat, or a specific detergent.
What about preventing those secondary infections you mentioned earlier? Staph, for example.
Infection prevention is paramount. Keeping the skin clean, treating any wound promptly, that's essential. For many chronic sufferers, the sources confirm the use of doctor-recommended diluted bleach baths.
That sounds intense.
It sounds intense, but the goal isn't to bleach your skin. It's to reduce the bacterial load on the skin, specifically that Staphylococcus aureus that often lives on eczematic skin and just drives more inflammation.
Let's shift our focus to the necessary architecture of skincare, because the underlying goal is always the same: restoring that skin barrier and getting the pH back to its naturally acidic 5.5.
The best products focus on providing functional ingredients, and they fall into three main categories. First, you have humectants, like hyaluronic acid or urea. These actually draw water into the skin.
So the magnets for moisture. And second, the structural support.
Exactly. Second are ceramides. If filigrin is the mortar, ceramides are essential fatty acids that act as the structural cement between the cells. Supplementing with ceramides is crucial for literally rebuilding that compromised barrier and preventing water loss.
And the third category is the sealants.
The emollients.
Okay.
Things like shea butter, olive oil, or dimethicone. These form a protective, oily layer on the surface to prevent the water you just put in from evaporating right back out.
So you want to look for products with those core components, plus maybe some natural anti-inflammatories.
For sure. Things like colloidal oatmeal, calendula, or chamomile, they provide that immediate soothing relief from the itch.
And just quickly, a mention of the newest pharmaceutical approaches. Besides the biologics, what other classes of advanced topical creams are now available?
We're seeing a whole new wave of highly targeted topical options. These include PDE4 inhibitors and JAK inhibitors. These are next-generation nonsteroidals that interfere with various inflammation pathways inside the cell, offering new avenues for aggressive symptom reduction without the long-term risks of traditional steroids.
The key takeaway from this entire dive seems to be that effective management is intensely personal.
Yeah.
You cannot treat dishydrotic eczema on your hands the same way you treat stasis dermatitis on your ankle.
You absolutely can't. You must first accurately identify the type. Is it primarily driven by genetics, like atopic, or by circulation, like stasis? And then you have to diligently track and avoid your specific personal triggers. That tracking is non-negotiable.
So at what point does home care stop and specialized medical attention become mandatory?
The sources are very clear on this. If your symptoms are severe enough that they interfere with your sleep or your daily activities, you have to seek help. If symptoms persist, even after using an over-the-counter hydrocortisone cream for one wet, it's time to see a dermatologist. And critically, if you see any signs of infection pus, yellow crusting, or red lines radiating from the rash, seek immediate care.
So what does this all mean for you, the listener? Well, eczema, particularly the atopic kind, might be unavoidable if you're genetically predisposed. But the difference between chronic suffering and just mild, manageable discomfort often comes down to early, consistent intervention.
And the final provocative thought we want to leave you with is this. We know stress is a proven trigger, and we know there's a complex interplay between diet, inflammation, and immunity. So how might radically integrating internal lifestyle management like focused stress reduction through mindfulness, or meticulously tracking possible dietary sensitivities, how might that dramatically reduce the severity and frequency of your personal flare-up cycle, maybe even more than the most advanced topical cream? The deepest solution often starts within.